Let us now discuss one of the important topics in neonatology, neonatal resuscitation. When a newborn is born and he does not cry immediately after birth, spontaneous breathing does not start, then we take a series of steps which are well organized, well scientifically evidenced, and these steps are called as neonatal resuscitation. All the neonatal resuscitation guidelines are guided by the program called as NRP program. NRP stands for Neonatal Resuscitation Program. It is run by American Heart Association in collaboration with American Academy of Pediatrics. Currently, worldwide, we are following the 7th edition. There is also a 8th edition which is due to come later this year, and it will be applicable from 1st January 2022. But as of now, in 2021, it is the NRP 7th edition which is being followed, and this is the one which is in public domain. It is expected that next year the edition might change. If there is a change, we at Doctutorials will be putting a complete update and overhauling the entire guidelines. But the guidelines are not expected to change much. The draft protocol I have read and it contains very little changes. I will be summarizing the proposed changes at the end of this session. So let us look at NRP 7th edition. There is a protocol, there is a flowchart which is given in your books. You might have tried to read about it. If you have not read it so far, it is a difficult flowchart. You should not miss steps, and every word which is mentioned should be followed accordingly. There are 3 types of questions which are asked in neonatal resuscitation in MCQ entrance. First is, they ask you directly about a one-liner. What is the bag and mask ventilation contraindication? What is the dose of epinephrine? So these are fact-based questions. Second type of questions are, they ask you clinical cases. They would say, a child was born, did not cry after birth, this thing was performed, now heart rate is this, tell the next step in the management. And third will be, they will put up visual questions related to the neonatal resuscitation. So we'll try to cater to all of these. Let us begin the discussion. So we have to form the protocol. So whenever a child is born, before the child actual birth happens, the protocol begins. The protocol says, initially there is a box. It has some features. It says that antenatal counseling should be provided. That is, the pediatrician, the neonatologist, should be involved in antenatal counseling related to the risk factors which might be present in a child. In our country, in our system, it is the obstetrician alone who looks after antenatal counseling. But ideally speaking, there is a role of pediatricians also in antenatal counseling. Before childbirth happens, there should be team briefing. It is a team effort. Multiple people are involved, including pediatrician and the nursing staff. And you should be doing an equipment check, whether the equipment which are there in the delivery room, they are working properly or not. So antenatal counseling, team briefing and equipment check all should be ensured before birth happens. So you reach the delivery room, you scrub yourself, check for your equipment, do the team briefing and wait for birth to happen. Now birth happens. The moment birth happens, you, the pediatrician, ask 3 questions to yourself. Is it term gestation? Is there good muscle tone in the child when he is born? And did the child breathe or cry after birth? These are the 3 questions we ask to ourselves, right? They are very, very important. Now, term versus preterm, you can easily say by looking at the file, the case records of the child. Good tone, how would you say good tone? Neonatal resuscitation, we don't have time to assess the child. You look and you say good tone. A child with good tone will be having some degree of flexion. He will have some movements happening. Whereas poor muscle tone, where there are no movements and child is like a rag doll, that is called as poor muscle tone. So for neonatal resuscitation purpose, there is either a good tone or a poor tone. Breathing or crying, obviously, we have ears, we have eyes, we'll see, we'll hear. If breathing or crying, either of the two has happened, that is again one of the question answered. So these are 3 questions which must be answered. If the answer to all of them is yes, all of them are yes, the routine care needs to be given to the child. So child stays with the mother, you provide warmth, normal temperature is maintained, position the airway, dry the child and evaluate. You should start breastfeeding as soon as the child is stable, mother is stable. So routine care needs to be given. There is a big table given in the protocol. The table I will share, I'll show you in the end, but this is routine care. So I'm trying to simplify the table, focusing on the keywords and explaining the meaning of all these keywords. If the answer to any of them is no, the child comes into the resuscitation protocol and we start with the initial steps. Initial steps. What are the initial steps that are performed? These initial step heading is not used these days if you look at the protocol, but traditionally, conventionally, we call them as initial steps. So in these initial steps, we will first of all provide warmth to the child and maintain temperature. You will take the child in your hands and bring under a open air radiant warmer. You will position the airway. If the neck is too flexed or too extended, it can compromise breathing in the child. You will clear the secretions if needed. You will clear the secretions. How will you clear the secretion? By suction. You will not use your hands. You can use a suction catheter to clear the secretions, mucus blood which will be attached. You will dry the child, right? And you will stimulate the child. Stimulation is very, very important. So this is the sequence of steps which is performed in initial steps. So these are the initial steps that you need to perform initially, and these initial steps should be performed very rapidly. So imagine you are the pediatrician. The moment child was born and any of the answer was no, you the pediatrician took the child in your own hands, bring under the radiant warmer. You will position the neck. Normally we do slight extension of the neck. We call it a sniffing position. All these points I will write separately. So sniffing position you will make. You will clear the secretions of the child taking a suction catheter. First you clear the secretion from the mouth, then from the nose. M comes before N. Then you will dry the child so that all the blood and evaporation losses, they can be minimized, and you will stimulate the child. Stimulation can be done by either rubbing the back or tickling, flicking at the sole once. These are the steps which should be done within seconds. After doing these steps, we check for two things. First of all, we check for breathing effort and heart rate. So breathing effort, if it is good, it is fine. But breathing effort, if it is poor, it can be either apnea. Apnea means absence of breathing, or it can be a gasping effort, irregular kind of jerky breathing. That is called as poor respiratory effort. So first we will look for whether the child is having apnea or gasping effort. That is poor respiratory effort. Second, we will look for bradycardia in the child. Is the heart rate less than 100 per minute? If the answer to any of them is no, both of them is no. If the answer to both of them is no, we will check for labored breathing, that is respiratory distress, and cyanosis. And if they are present, if present, you will start the child on supplemental oxygen and you will monitor the child. If there is no response, you will consider starting CPAP, continuous positive airway pressure in the child. Anything going to the right is child moving out of the resuscitation protocol. So basically, if the child is not having any poor respiratory effort, no bradycardia, so you will just check for labored breathing and cyanosis. If any of them is absent, nothing needs to be done. If they are present, you will start with oxygen, monitor. Basically, resuscitation part is you are basically coming out of the resuscitation protocol. If the answer to any of them is yes, then the child continues into protocol, and now we have the first proper step, not the initial step. We start the patient on positive pressure ventilation, PPV, using bag and mask ventilation. So you will start with positive pressure ventilation. You will forcefully push air into the system of the child. There is a ambu bag which has a mask attached in the front. You put the mask covering the nose and mouth of the child, start pushing air into the airway of the child. If I have to show you a picture, this is how ambu bag looks like. This is the face mask which is present at the top, and this is the ambu bag, right? And this is the source of oxygen if you need to attach, and you can also attach a small bag here which is called as a reservoir. This reservoir is a separate attachment. It may or may not be attached depending upon the need. So you will put this circular mask over the nose and mouth of the child and start pushing air into the system. We call it as positive pressure ventilation. Simultaneously, you will start monitoring. You will attach the child to monitor. SpO2 and ECG monitor need to be attached to the child. So you, the primary pediatrician, will be giving positive pressure ventilation. The supporting nursing staff will attach the child to monitor. You will check for saturation and you will check for ECG tracing in the child. Once you have started PPV, you will not give for few seconds and then check again. You will continue for minimum 30 seconds. After 30 seconds, now you will not check for apnea or gasping. You will check for heart rate. Is the heart rate less than still 100 per minute? Is the heart rate still 100 per minute? Because if your PPV is effective, the heart rate will pick up. If the heart rate is not below 100 per minute, if the answer is no, you will give post-resuscitation care to the child. Right? If the answer is yes, bradycardia is still persisting, you will perform ventilation corrective steps. Whether the steps you are doing, whether the ventilation which you are giving, it is effective or not, whether the mask you are using is properly attached or not, the size is proper or not, seal proper bana hai ya nahi, whether you need to give oxygen, whether you need to consider alternate airway. So these ventilation corrective steps need to be checked for, and we can consider alternate airway. You will take the ventilator connective steps, consider alternative airway like endotracheal tube, you can consider it, and you will check for chest movement. All these will be done in this step. Then you check again. After taking a pause for 30 seconds, within 30 seconds you check this and again check. When the heart rate dips less than 60 per minute, if the answer is heart rate is still less than 60 per minute, you will take on doing these ventilative corrective steps. But if the heart rate dips less than 60 per minute, now it is a danger sign, it is severe bradycardia. In this patient, now you will intubate the child, put an endotracheal tube and start positive pressure ventilation through endotracheal tube. Now you are not using a mask, you are using a tube to intubate and give ventilation. Plus the second person, your assistant, will come from the front and he or she will start giving chest compressions. So ventilation and chest compressions both will be needed. At this step, 100% oxygen should be given. The concentration of oxygen should be given is 100% oxygen, and the ventilation and compressions should be coordinated. You need to coordinate these steps which you are doing. Then do it for 30 seconds, then check again. Heart rate is still less than 60 per minute. Then you will consider epinephrine in the patient. So IV epinephrine will be given, or drugs will be given in these patients. And after giving epinephrine, you will go back and try to see if you will, in bracket you will write, you will continue positive pressure ventilation and chest compression in these patients. So these two will continue in these patients, and you need to, in bracket, rule out other causes like hypovolemia and pneumothorax. So hypovolemia and pneumothorax can interfere with proper resuscitation, they need to be ruled out. This entire thing, what we have written here, is called as the neonatal resuscitation protocol. This is the one you are supposed to remember, make it with your own hands and write it down. I will show you the actual protocol also, but I have just simplified the language, and this is relatively a bit easier to remember rather than the complete protocol. You cannot change these wordings, you cannot change these steps, you cannot change the sequence of the steps which are being performed. So this is called as neonatal resuscitation protocol. Let's have a look here. This is the actual resuscitation protocol which is provided to all healthcare providers. It is more colorful. Yeah, it looks very similar to what I have discussed, but I have tried to explain in simple words. Let us try to go and revise it once again, looking at the keywords here. So it started with antenatal counseling, team briefing and equipment check, right? Then you scrubbed yourself and waited for the birth to happen. Once birth happened, you ask 3 questions to yourself. Is it term gestation? Is it good muscle tone? Is there breathing or crying? If the answer is all 3 is yes, then routine care needs to be given. All these are basically routine care. You need not remember them. But if answer to any of them is no, the child comes into the resuscitation protocol. These are the initial steps that we perform. You provide warmth and maintain temperature. You correct the posture of the child, maintain airway. You do suction to clear the secretions if it is needed. You dry and stimulate the child. Stimulation should be done only once. Stimulation is done by rubbing the back or flicking the sole. Then you check for poor respiratory effort and bradycardia. If none are present, you check for labored breathing and cyanosis and give supportive oxygen or CPAP if they are needed. If the child is having any of them, either bradycardia or poor respiratory effort, you start with positive pressure ventilation. Initially, we start with bag and mask. Your nursing staff or assistant will attach the child to monitors. After giving PPV for 30 seconds, you check for again heart rate improvement hua ya nahi. If it happens, if heart rate is not below 100 per minute, bradycardia is gone, you will give post-resuscitation care, team debriefing. Debriefing means now everything is fine. Let us discuss later what all can be improved. That is team debriefing. If bradycardia is persisting, you will take the ventilation corrective steps and consider alternative airways. If heart rate dips below 60, that is severe bradycardia, you need to intubate the patient, consider chest compression, coordinate the two. What is coordination? When you are giving breath to the child, the other person will not compress the chest airway. Chest, right? Because if you also give air and the other person does chest compression, it will cause injury, it will cause pneumothorax to the child. So, there is always a ratio which is obtained. There is 1 breath which is given followed by 3 compression, or the compression to ventilation ratio is 3:1. So 1, 2, 3. 3 compressions are given followed by 1 breath which is provided to the child. So that is called as coordination. 100% oxygen will be needed and you will attach to monitor if not already done. Emergency umbilical vein catheter can be put because we need to give drug in the next step. It is a consider, like it is not mandatory. Once heart rate is below 60, then epinephrine needs to be given. If it continues, you need to rule out these 2 conditions. This is called as the neonatal resuscitation protocol. Very, very important. And when you are doing resuscitation, what is the target saturation when you are doing? These are given in this table. At 1 minute, it should be 60 to 65%. 2 minutes, it should be 65 to 70%, 3 minutes, 70 to 75%, 4 minutes, 75 to 80%, 5 minutes, 80 to 85%, and 10 minutes, it should be 85 to 95%. This is one table, which is a fact-based thing that you need to remember. This is called as the neonatal resuscitation protocol. So after discussing about this neonatal resuscitation protocol, let us discuss the finer points of each step and the one-liners which you need to remember related to those. Try to visualize the protocol as you are reading. It will be always easy for you to remember. So what are the key points regarding neonatal resuscitation that are important for your exams? So whenever delivery is going to happen, what should be the temperature in the delivery room? There are 2 types of MCQs which are asked. Temperature in delivery room and temperature in ICU. Temperature in delivery room should be between 25 to 28 degrees Celsius. Ideally, it should be 25 degrees Celsius according to OP Ghai. So ideally, it should be 25 degrees Celsius. Whereas if question says temperature in newborn ICU, NICU, then the answer will be 22 to 26 degrees Celsius. So 2 different questions are asked in exam. Please do not get confused. Whenever you are doing resuscitation, there is a concept called as golden 1 minute of resuscitation. What is golden 1 minute of resuscitation? See, any child, if he does not require resuscitation, fine. But if a child requires resuscitation, the first positive pressure ventilation should be started within 1 minute of birth. What it means is that all these steps, starting from birth till assessment till initial steps, should be done within 1 minute of birth. That is because any hypoxia occurring in 1 minute is well tolerated by the child and the overall outcome is good. If this 1 minute period is crossed and resuscitation, positive pressure ventilation is delayed in the child, permanent neurological damage can happen to the child. This is scary because if you are not well versed with the condition, long-term neurological status can be impacted, and who will be responsible? Of course, the neonatologist, the pediatrician, because and that is why there is a lot of stress which is paid up in MCQs, in curriculum, in undergraduate level, postgraduate level on neonatal resuscitation protocol, because there is no permanent damage. If resuscitation is started within 1 minute, we call it as the golden 1 minute of resuscitation. It was asked in AIMS entrance exam some years back. So golden 1 minute means any neonate who needs resuscitation, the resuscitation needs to be started within 1 minute of birth. So start positive pressure ventilation within 1 minute of the birth. That is called as golden 1 minute of neonatal resuscitation. Let us move ahead. We talked about suction of the child. So suction can be done by suction catheter. First you suction mouth of the child, then you suction nose of the child. M comes before N. If you suction nose first, any mucus in the mouth can be aspirated by the child. So first we suction mouth followed by nose, and it is done by catheter. The suction catheter size used in newborn is either 12 French or 14 French. So 12 or 14 is the size of suction catheter that is used in newborns. Next we come to stimulation. I had mentioned that stimulation of the newborn needs to be done in the initial step. Stimulation can be done by either rubbing the back once or trickling or flicking the sole once. So you give one painful stimulus or a strong tactile stimulus to the child. It should be given only once. Some residents, interns, I often see they start giving a massage to the child. Don't give massage. The child does not need your massage. It just needs one tactile stimulation. If it has not started breathing, don't waste time. Golden 1 minute is crossing. Move to the next step and assess and start positive pressure ventilation if needed. So stimulation can be done by rubbing the back or flicking the sole. And when you are making a position of the child in an initial step, what is the position you should be using? It should be a sniffing position. Slight extension of the neck. It should be slight extension of the neck. All these are, see, I'm writing them in one-liner form, but they are all related to the neonatal protocol. If I had tried to enter all these points in the protocol, it would make it look like a khichdi. I don't want to make it like a, a mixture of too many things. So I have discussed the protocol, meaning of each term, and step-wise what each step having some or the other peculiar abnormality, MCQ point that I am discussing at this place. So then, once you start positive pressure ventilation, how do you give it? Positive pressure ventilation is initially given by bag and mask ventilation. Right? Bag and mask ventilation, it is contraindicated in congenital diaphragmatic hernia, as well as a condition called as tracheoesophageal fistula. If both of them are mentioned, which will be the better answer? This will be the better answer because it is absolute contraindication for diaphragmatic hernia. Tracheoesophageal fistula is a relative contraindication. Earlier, meconium, that is first stool of the newborn, if it is passed, we call it as meconium stained baby. If that used to be there, again it used to be a contraindication. Now that is no longer a contraindication. What is the bag which is used here? The bag is called as ambu bag. The size of this bag is between 240 to 750 ml. How much concentration of oxygen it can give? It can deliver 40% oxygen normally. And if you attach to oxygen source, room air pe to obviously nothing will be provided, and it can deliver up to 90 to 100% oxygen if you add a reservoir at the end. I have already told you that this is the mask, this is the ambu bag. At the end of the ambu bag, you need to attach oxygen, and at the other end, if you attach a reservoir can increase the oxygen being delivered through the mask. When you give bag and mask ventilation, the rate of bag and mask ventilation should be between 40 to 60 per minute. The first breath you give usually requires a higher pressure. It requires a pressure of about 30 to 40 centimeters of saline. This has been, you actually don't measure it yourself, but this has come from the studies. So it's a fact-based thing. And subsequent later breaths, they will require only 15 to 20 centimeters of saline. Both of them have been asked in MCQ entrance exam 2 times. Now, when to use room air and when to use oxygen? Very simple. In case of term babies and preterm babies, equal to or more than 35 weeks. So 35 to 37 wale babies plus term babies. You start the ventilation on, start positive pressure ventilation on room air, right? Whereas in preterm babies, less than 35 weeks, you start the positive pressure ventilation on only 21 to 30% oxygen and increase as you increase the, if there is no clinical response, and it's a clinical decision whether to increase it or not. However, when you give chest compressions, at that time 100% oxygen needs to be given. This is again a scenario based question which is asked in AIIMS entrance exam. When will you give room air? When will you use 21 to 30% oxygen? When to give 100% oxygen to the child? Remember, as resuscitation is done, the best predictor of improvement in the baby, is increase in the heart rate. So improvement in heart rate, this is your AIIMS MCQ. It is the best predictor, and that is why if you see heart rate less than 100, heart rate less than 60, we are taking clinical decisions based upon improvement or not improvement happening in the heart rate. Next we come to what is the ventilation corrective steps. Ventilation corrective steps that we take can be remembered by the mnemonic called as MR SOPA. What is MR SOPA? M stands for mask readjustment, right? R stands for repositioning of the head. You check the position of the head and reposition it. S stands for suction. You try to remove any mucus, any blood clot being there in the mouth of the child, which is not allowing the resuscitation, which is not allowing the ventilation to be effective. O stands for you open the mouth. It slightly opening the mouth improves the ventilation in some of the individuals. P stands for pressure. Pressure of ventilation should be increased. You should not be, too gentle while ventilating. Give a proper push, and sometimes the baby's ventilation tends to improve with that. And A stands for consider alternate airways. So alternate airways need to be considered. So these are the ventilation corrective steps that we perform. Then we come to if you have to intubate the patient. If you have to intubate the patient, remember that you should be using a uncuffed tube in newborns. Cuffed tubes are used in older children. PALS protocol talks about cuffed tubes. Neonatal resuscitation talks about uncuffed tubes. It should not have a cuff in that. And when you are intubating, you should be using a straight blade instead of a curved blade. So straight blade should be used. Then what is the ratio of chest compression to ventilation? Ratio of chest compression to ventilation, it will be 3:1. What is 3:1? 2 times MCQs have been asked. So the person giving compression will give 1, 2, 3. Then 1 ventilation will be given. 1, 2, 3 breath. 1, 2, 3 breath. What should be the speed? In 1 minute, there should be 90 compressions and 30 ventilations or 30 breaths should be provided. Total 120 events should occur in 1 minute. There was an MCQ asked some years back. Total number of events in cardiopulmonary resuscitation in newborn. Many people did not understand the meaning. When we say event, they include both compression and ventilation. The total number of events in such cases is 120. Then we move to, remember we were attaching the saturation probe to the child. So where will you attach the SpO2 probe? In you and me, whether I attach a SpO2 probe here, here, saturation will be same, right? I attach here and here, it will come same. But in a newborn, there is still ductus arteriosus which is open, and it can produce, if you remember the location of ductus arteriosus, it is just adjacent to the origin of left subclavian artery, and beyond that you have the descending aorta. So we need to attach SpO2 probe in a organ, in a limb which is supplied by a structure which is distal to that. Try to look at the anatomical basis of this concept. This is your arch of aorta. This is your right brachiocephalic trunk. It divides into right subclavian artery and right common carotid artery, right? This is your left common carotid artery. This is the left subclavian artery, and this is the site where ductus arteriosus is normally attached. In a child who is just born, this ductus arteriosus will be open. There may be a left to right or right to left shunt operating depending upon the pulmonary pressure. This can interfere in the oxygen, in the saturation capability of a particular limb, of a particular vessel. So we try to apply the SpO2 probe in the right upper limb. This is your AIIMS MCQ, NEET PG MCQ. Why? Because it is supplied by right subclavian artery and it gives the most accurate value of saturation. We also call it as preductal SpO2. So remember, in newborn, as a shortcut, always attach SpO2 probe in the right upper limb, not in any other limb, right? Then what is the, when we give epinephrine, resuscitation and ventilation, all these steps which you were doing, they need to be continued. You give epinephrine. What is the route through which we give epinephrine? The fastest route is in the umbilical vein. Umbilical venous route is the best. If that is not possible, second fastest is intraosseous. If you can't find umbilical venous route, you can give into the tibia. If that is also not possible, you can give endotracheal route. And finally, you have the peripheral venous route, because finding a vein and putting a catheter is tricky in case of newborns. What is the dose of epinephrine? The dose is very, very important. It depends upon the concentration. The dose of epinephrine given in these children is 0.1 to 0.3 ml per kg of a 1:10,000 solution. When you calculate in mg per kg, it becomes 0.01 to 0.03 mg per kg. Please remember this. When the dose is being asked in ml per kg, it will be 0.1 to 0.3, and when it is mg per kg, it is 0.01 to 0.03. It is related to the dilution, how we dilute epinephrine, and the strength of the solution is 1:10,000. In children where you need to use endotracheal route, if you are using an endotracheal route, higher dose needs to be given. You need to give 0.3 to 0.5 ml per kg of this solution. The strength of the solution becomes 1:1000. And here, because the strength is more, the dose will be 0.3 to 0.5 mg per kg. I know it sounds very tricky, but they are very frequently asked. This is the intravenous or intraosseous dose that you need to remember. So ET route dose and IV or IO dose of epinephrine needs to be remembered. Eventually, let us talk about resuscitation in meconium stained liquor babies. MSL babies. MSL stands for meconium stained liquor. Meconium is the first stool of the newborn, right? Ideally, it should be passed after birth. Certain children, particularly those undergoing fetal depression, perinatal depression or asphyxia, they can sometimes pass meconium in utero. If that meconium is aspirated, that can cause problems in the resuscitation. And so, whenever a MSL baby is born, the protocol looks something like this. There are older protocols you will follow. What I am discussing here is the latest one. It has been changed. So, any MSL baby, whenever he is born, MSL means the gynecologist will tell you that, sir or ma'am, the baby has already passed meconium in utero. So now the protocol gets slightly changed. The moment baby is born, the first step we do is not doing initial step. We check whether the baby is vigorous or not. So this is very important for your exam. This is an exception to the resuscitation protocol we have just done. So check whether it is vigorous or not. Who is a vigorous baby? A baby is said to be vigorous. The term vigorous is used only in meconium stained liquor babies, right? If the heart rate is equal to more than 100 per minute, if there is good respiratory effort, and if there is good muscle tone, all three should be present. We call it as vigorous baby. If the baby is vigorous, routine care needs to be given, right? In case the baby is non-vigorous, either there is bradycardia or respiratory effort is poor or muscle tone is less, you will start resuscitation. When you start resuscitation, provide warmth to the child and bypassing all other steps. Warmth, dry, and immediately start positive pressure ventilation using bag and mask ventilation. Bag and mask ventilation is no longer contraindicated. Remaining steps will be similar. So similar steps will be done for the remaining things. So positive pressure ventilation needs to be started as early as possible. When I was a resident, I was preparing for PG entrance exam. At that time, the concept was you clear the airway, you do suction of the airway, you do suction of the mouth. All these things have been discarded now. Very clear, very simple. Non-vigorous baby, bring under the radiant warmer, clean the skin, put the bag and mask and start giving air to the child and do the whatever things, other things which you will be doing for any other normal resuscitation. And monitoring also will be done on the similar lines. So this is regarding resuscitation in MSL babies. In neonatal resuscitation, there is a scoring system that we need to remember called as APGAR score. APGAR score was originally devised by an anesthetist for telling about whether a child needs resuscitation or not. Later it was found that the score is more useful retrospectively to tell the degree of asphyxia and whether the patient will have mortality or not. So the first thing that you need to remember is APGAR score is not used to guide resuscitation. It is not used to guide resuscitation. It predicts severity of asphyxia and predicts mortality of asphyxia, right? What are the components of APGAR score? The components, three types of scores can be given. On one side, you would write the component, individual component, then three types of score, 0, 1 and 2. 0 is a low score, 2 is a high score, 1 is intermediate score. First is A. A stands for appearance. Score of 0 is given if the child is pale or cyanotic. If the child is having peripheral cyanosis, only peripheries are blue, we also call it as acrocyanosis. We give a score of 1. And a score of 2 is given if the child is overall pink. P stands for pulse, that is heart rate. If it is absent, score of 0. Less than 100 per minute, score of 1. Equal to or more than 100 per minute, score of 2. Third, G stands for grimace. Grimace stands for reflex irritability. Reflex irritability. What is grimace? We take a wasp of cotton and irritate the nostril of the child. If there is no response, we call it as score of 0. If the child makes an expression like this but does not cough or sneeze, we call it as grimacing action of the face, score of 1. And if the child coughs or sneezes or tries to pull away, we give a score of 2. Next, A stands for activity, also called as muscle tone. If there is no activity in scores, give a score of 0. If there is some degree of flexion, we give a score of 1. If actively moving the limbs, flexion plus extension of the limbs, in bracket you would write actively moving, good muscle tone, you will give a score of 2. And finally, R stands for respiratory effort. It is not respiratory rate, respiratory effort. If it is absent, you will give a score of 0. If it is irregular breathing, you will give a score of 1. If there is regular breathing and the child is crying, you will give a score of 2. These are the components of APGAR score that you need to remember. Then we calculate and total the scores. So what is the interpretation? If the total score is 7 to 9, that is considered to be normal. If it is 4 to 6, it is considered to be intermediate. And 0 to 3 is considered to be a low APGAR score. These are the children who have high mortality. They will have severe asphyxia. It is one of the criteria for hypoxic ischemic encephalopathy. And when you do APGAR score, conventionally APGAR score is done at 1 minute of life and 5 minutes of life in all newborns as a routine monitoring. In case of asphyxiated newborns, it needs to be done at 1, 5, 10, 15 and plus minus even 20 minutes in case of asphyxiated newborns. And 1 minute score is considered to be the least sensitive score. It is the 5 and 10 minute which are more sensitive for degree of asphyxia in the patient. Finally, the very important thing. What are the proposed changes? So changes which are proposed in the NRP program 8th edition. I am only highlighting the things which they have said will surely be incorporated. Actual NRP program will be released in the month of July. The details will be released in the month of July 2021. So whenever it is released and whatever are the details, we will put a small additional summary of that in the app as well as for all of you people who are listening to it. So what are the changes they have proposed? First of all, the initial steps have been modified. So initial steps have been modified. The sequence of initial steps now in the 8th edition, it is still not applicable, but now it is going to be provide warmth, dry, then stimulate, then position the airway and then suction if needed. So this is the initial steps, this is the sequence that needs to be followed instead of the sequence which we have discussed. Second, the epinephrine dose has been modified. It is not yet modified, but it is proposed to be modified. You need to understand that these are proposals which are supposed to be incorporated. In case it is a IV or intraosseous dose, the dose has been proposed to be changed to 0.2 ml per kg of, instead of a range being given, they are proposing a midline value 0.2 ml per kg of 1:10,000 solution, which will be 0.02 mg per kg. So fair enough, right? But the endotracheal dose has been changed. They say endotracheal dose should be 0.1 mg per kg. If you are using the same solution, it will come to be 1 ml per kg. And if you are using a 1:1000 solution, it will be 0.1 ml per kg. So ET dose, they have only defined in mg per kg, not as ml per kg. And finally, they have proposed when to consider stopping resuscitation. You can't do it indefinitely. If all steps have been performed properly and heart rate is still absent for equal to or more than 20 minutes after birth. So 20-minute cutoff has been given. Then you need to consider stopping resuscitation in these individuals. So these are the changes which are proposed in NRP 8th edition. And finally, we will finish with what are the conditions where neonatal resuscitation is not effective or can be stopped or not done. Not done is not an option, but neonatal resuscitation is not going to be effective. First of all, they are all conditions which are incompatible with life, which includes anencephaly, not compatible with life, do not resuscitate. Trisomy 18, Edward syndrome, do not resuscitate. Trisomy 13, do not resuscitate. Heart rate absent for more than 20 minutes despite resuscitation, this we have already done. This point can also come here. Down syndrome has to be resuscitated. Other syndromes have to be resuscitated. Other neural tube defects have to be resuscitated. So this is regarding neonatal resuscitation. What I have tried to do is to give you a picture of the protocol and each point which is related to the individual things related to protocol. You can get visuals in the paper. How visual can be asked? They will say, look at this picture and tell which step is being performed. So, and which of the two needs to be done, which is correct. The answer will be both of them are correct. They are basically, you are giving resuscitation to the child through chest compression. So, this is called as the two thumb technique, whereas this is called as the single hand, also called as two finger technique. Two thumb, two hand technique, and this is the single hand, two finger technique. Both of them can be used depending upon your preference and depending upon the size of the child as well. So this finishes our discussion of neonatal resuscitation. Before I go, let us take an example of a question. If the question says, a newborn was born at term, did not cry immediately after birth, resuscitation was started, and currently the newborn is undergoing positive pressure ventilation, PPV has been done for 30 seconds and heart rate is 110 per minute. What is the next step in management? Lot of people follow the protocol blindly and they say after heart rate ventilation corrective steps need to be done. Other people think of intubation. No, heart rate is now not below 100. If heart rate has improved, child comes out of resuscitation protocol, post resuscitation care will need to be given. Such type of clinical scenarios, they are there in the question bank. I'll be taking live sessions where I will be discussing about these. Be thorough with this module. Any other queries are most welcome. What we know is a drop. What we don't know is an ocean. It holds true for resuscitation. It holds true for any topic in the world of medicine. Thank you.